Hi, I'm Dr. Gay Carlson, President of the American Academy of Child and Adolescent Psychiatry, with number 30 of my Screenside chats for our AACAP members. My goal, as you know, with the chats is to share timely clinical practice and other important information from experts on key topics during the COVID-19 pandemic. Reminiscent of President Roosevelt's fireside chats during the Great Depression and World War II, I've wanted the topics to be informative, relevant, and interesting. Today, we're continuing the theme of addressing the other pandemic of the crisis in child mental health and access to care. It's important that we develop innovative ideas of how to get treatments to people that are user-friendly, effective, and can address a large group of kids and families with needs. One of the innovators is someone I'm pleased to say is at Stony Brook, where I work, Dr. Jessica Schleider, who's an assistant professor in the Department of Psychology and Clinical Psychiatry Psychology PhD program at Stony Brook University. She serves as a faculty affiliate at the Alden Alda Center for Communicating Science and was an academic consultant to the World Bank's Educational Global Practice. She was trained at Swarthmore, Harvard, and Yale before coming to Stony Brook. Her research on single-session interventions for youth depression and anxiety has been recognized with numerous awards. I'm not going to go through all of them because there's just many of them, but I'm going to mention and put in a plug for the fact that one of her awards was an affiliate with AACAP, and that is the Klingenstein Foundation. We're the consultants with the Klingenstein Foundation to help disseminate awards for people doing research in healthcare delivery and depression. And I'm pleased to say Dr. Schleider was one of our awardees. So Dr. Schleider, I'm going to ask you to tell us what single session interventions for youth are and give us a feeling for what a clinician has to do in order to help their patients use this kind of intervention.
Sure. Really happy to be here. Thank you so much again for the opportunity to chat with you about single session interventions. They're often things that clinicians don't know much about or aren't sure how to use in practice. So I'm happy to be able to share some insights and ideas for how folks could apply them. So single session interventions are not new. They've actually been around for more than 30 years, going back to late 80s, early 90s, when they were first sort of conceptualized by Dr. Moshe Tellman in a book where he defined what SSIs are as essentially sessions that are intentional about the reality that sometimes the first meeting between a client and a therapist is actually the last meeting.
That's right. You got one shot and this is it.
Yes. Often that happens accidentally, right? So you don't realize that one person isn't going to come back for a second session due to a host of logistical, structural, financial factors, but that ends up being the case. In fact, there's a lot of research showing that the modal number of therapy sessions that folks actually receive is one. So single session interventions are just the shared awareness between the client and the patient that this hour together may be what we have. And even though that seems like a short period of time, there's this shared belief, and the therapist can instill the belief that change is possible in any given moment, that any moment can serve as an opportunity for self-reflection, realization, learning that could change the trajectory of someone's recovery or well-being. So it's that framing that makes single session interventions what they are. Rather than assuming that there will be a long-term therapy relationship, taking each session as a one-at-a-time opportunity to make change.
If this were a blind date, the idea would be, this is it. We're probably not going to have any further dates after this, but we're going to enjoy this one.
That's exactly right. And, with a single session therapy approach, we actually here at Stony Brook at the Krasner Psychological Center and also in the psychiatry department deliver something called the single session consultation program for folks on waiting lists for therapy. Often people who are waiting for treatment get worse while they're waiting, and waits can be quite long. So the single session consultation is an opportunity for a therapist and a client to meet once, make an action plan around a specified goal, and help that person get a very small step closer to a reality that they want for themselves. So it's very goal directed, very specific. It's not trying to do anything that can't be done in one session, but that, belief that change can happen in any given therapeutic interaction is really key, and often instills hope in clients. There's a whole lot of literature behind this for young people in particular. We also have digital single session interventions that are totally self-guided. Happy to talk about those as well.
So tell us how you got interested in this, Dr. Schleider.
Sure. It was genuinely out of frustration with a lot of existing approaches to getting treatment to young people who needed treatment. The vast majority of kids who need help, mental health wise, do not receive anything at all. And I was trained in intervention science and in delivering individual psychotherapy, and saw over and over again these problems of early dropout from one-on-one treatment due to barriers that the family was experiencing, school-based interventions not getting to students because they were absent, or just other implementation issues at the school level. Community-based interventions just not really sticking or having a really hard time getting delivered. So all of these solutions to the problem of access to care didn't seem to be working. And I got really interested in, often as an outpatient therapist, I only saw folks once for one reason or another. What if I actually tried to do something in that one session instead of just do an assessment like I would typically do? And that got me thinking and really studying this idea. And as it turned out, I was far from the first person to think of this. There was a whole bunch of literature out there on single session approaches. And I ended up doing a meta-analysis and sort of putting together all the literature on single session interventions for youth. We found that they were effective overall. And even had effect sizes that were comparable to full length, like 4-month-long treatments based on other meta-analyses. So I was super excited and encouraged by this, at the same time as being a little confused as to why they could match the efficacy in some cases of longer term treatments. But that's how it started.
So walk me through, if I call your clinic and say, hey, I've heard this of this Dr. Schleider person, and she does something in one session. What? Tell me where I go. Tell me where I take my daughter, quick.
Absolutely. So there are a couple different paths as a clinician. Of course, as a provider, you are one person. And that is the difficulty of being a therapist, is that you can't treat everyone who needs your help. And for that reason, we've been really focused in my research lab on developing digital single session interventions that youth, and specifically teenagers, where there's this huge increase in anxiety and depression during those years, that teenagers can actually do on their own, self-guided, fully independently. We have our evidence-based single session interventions that are all digital, all self-guided, on our website for free. So any clinician can go on and use them, send the link to their clients if they're, facing a wait for treatment. And teens can actually self-guide through those programs. And all of them teach us a different skill, pretty common in cognitive behavioral therapy. So one of the single session programs, which takes about 20-30 minutes for teens to do, teaches behavioral activation. So doing valued activities to combat low mood. One of them teaches this idea that it's often called growth mindset, that symptoms like depression, anxiety are in fact malleable simply because of how the brain works and how neuroplasticity works. Another intervention that we have on that website teaches self-compassion and how to do self-compassion, even when it feels hard and even when you feel that maybe you don't deserve it. So they each teach a very specific skill. They offer opportunities for teens to give advice to others. We have an advice center where we collect that advice.
That's really brilliant. Okay.
Yeah. And so teens can do this on their own, which of course speaks to their need for autonomy. And often what we hear from the teens who do our research is the real desire for privacy, and to kind of do these things on their own terms. So we found this to be super helpful. Actually, during the pandemic, we ran a national clinical trial that was funded by the National Institutes of Health that included almost 2,500 teenagers with depressive symptoms across all 50 US states. And two of the interventions that we have really available on our website outperformed a control in reducing depression symptoms over 3 months.
That is just amazing.
We were really, really excited. It's under revision now. So I'll have a hopefully published paper to point you to soon. The preprint is online. But yeah, so we're really happy with the prospect that these brief supports can do something, even if it doesn't fully, match what full-length treatment could do. If somebody isn't able to access anything else, it's an option. So yeah, clinicians can offer this to anybody, and our protocols for therapist-delivered interventions are all open access as well.
Well, that's not only brilliant, but it's also a gift. It sounds like to a lot of people. So basically, what you and we can publicize the website at the end of this and put it up on the AACAP website so people can access it. So it sounds like the teen can go onto the website and say, "Oh, let me try this one," or "Let me try that one," or "Gee, let me try all three of them." Or is that how it would go? Okay.
It is a choose your own adventure experience for the teenager doing it. So they get to pick which intervention they want to try. They can try multiple if they want. They can go through it as many times as they'd like. It is anonymous. So they don't have to worry about somebody finding out what they say in the intervention. And at the end, we give this opportunity to contribute to our advice center. So teens can use their lived experience and expertise in coping with depression or anxiety to actually advise peers. And we've collected hundreds of advice from teens, and they're all together in a really neat collection.
But what are some of the best ones you've gotten?
Oh, I can go and look at them right now. But a lot of them focus on this idea of there is hope. Even if you feel like there is not, even if you have felt terrible for the longest time and nothing has worked, that doesn't mean you can't feel better at some point. That does not mean things are stuck. And that is really the message of a lot of our interventions, which is really exciting to see folks really internalizing and capitalizing on. But I just opened our advice center. So one person said, I would tell someone who's struggling with depression and anxiety to just try to slow down. Everything has to work out because time will pass and things will be okay, for better or worse. So slow down, take it 1 minute at a time. I promise it will work out. Another said, if I were to give any advice, it would be kind of cheesy, but I would say to find the light of any situation you're in. So there are a lot of different, it ranges very enormously, but it's lovely to read through these. And it's exciting to have collected so many at this point.
So it sounds like part of the sell or part of the grab, whatever you want to call it, that's attractive to the kids is that there are other kids that are telling them that. So if you tell them that, or I tell them that, or their mother tells them that, or whatever, it's
right.
Like, oh, so much.
Exactly. Our interventions are all built around this frame of youth empowerment. And in fact, the website is called Project Yes, which stands for Youth Empowerment and Support. And the entire goal is not for adults or authority figures to tell teens how to cope, but for teens to find on their own what's going to work for them. And for teenagers, having taught middle school math before I went into clinical psychology, I learned many, many times in many ways that teens want to do things on their own terms. And they want to feel ownership of the things that they learn and try. And we've tried to incorporate that into our online single session programs.
So what do you think is the future? Where are you going to go next with this? How do you expand this? I mean, we do have a mental health crisis, and I don't expect one intervention is going to cure everything. But where right? But so where do you see this? Where do you see this fitting in? Where would you want to go next with this?
So one important thing that I want to emphasize is that I do not, and can't even imagine single session interventions replacing anything else we already have. They have to be one piece of a fabric of a larger mental health care ecosystem. And I think they have potential to fill gaps that traditional treatments just aren't set up to fill and never will fill. So I think we have a couple of different broad goals for the next steps for this kind of work and getting these things out there. One is just testing every possible setting and seeing where these fit in best, how they should be delivered to teens. We often go to social media, Instagram, to actually give the interventions directly to teens. So one question we have is whether it's best for teens to find these on their own and try them out, or whether they should come from clinicians, or whether it's helpful for them to be in primary care clinics or for waiting list situations.
Well, you said you used to be a math teacher. I would have thought that this would have been a great thing for school psychologists to have in their repertoire.
And we work with several different schools and school districts to figure out how to best implement these programs. But as usual, implementation is the challenge. And getting these into the workflow of school systems is not as easy as you might think for a free online intervention. So those complexities have to be really carefully thought about at the local level, at the setting level, which creates a lot of complications for implementation in any setting, even for something so simple.
So give me an example of the kinds of issues then that you're likely to run into.
Yeah, so one is the issue of parents' permission. And that comes into play in pediatric primary care, in schools, and just trying to figure out to what degree should and can teenagers be able to do these on their own without parent permission. A big component of our interventions is teen empowerment, but a lot of systems are set up to disempower teens from actually taking ownership of their own mental health care decisions. So that's one of the biggest barriers that we face over and over again. Different states have different laws about whether teenagers can or cannot access mental health supports independently. That's one big one. The other is who is going to connect teens to these? Or are they part of a sort of larger infrastructure? Who's going to monitor whether teens complete them? So I think there's just a lot of behind the scenes stuff that needs to be worked out and that it organizationally has to be addressed in order to implement these in institutions. And that's a huge challenge in implementation science broadly, but we've definitely come up against it over and over again.
Mm-hmm. So if a teen accesses it by his or herself through Instagram or some sort of direct thing, direct to client, direct to consumer,
right? Direct to consumer,
or whatever, it's right?
Free, but yeah,
right. If they're able to access it, then that's no problem for you. The problem comes with, if we wanted to do it. So if we want to do it in our clinic here at Stony Brook, or if I put it down as I work with schools a lot, and I were to put it in my recommendations, have teen, try this website. What you're saying basically is the school couldn't necessarily just sort of do that willy-nilly. They would need to make sure that it passed whatever muster they have before they would promulgate it. Is that what you're saying?
Yeah, I think there are different levels of openness to offering these things directly to teenagers in different schools and different districts, different settings. And that makes it really challenging to do broad scale implementation. It's also an open question whether it makes a difference if teens hear about it from their peers on Instagram or their teacher or their parents.
Yeah. I would almost think if you heard about it from an adult, it was the kiss of death.
Exactly. So that's a testable empirical question, which I don't know the answer to. All of our large randomized trials have been totally social media based in terms of recruitment.
Okay. Well, that's interesting.
Yeah.
Does it ever fit into a spectrum of things? So, I think you've got a, pretty realistic view of, somebody's hearing voices or ready to jump off a bridge or that it's not trying to cure all of mental health problems.
Of course.
Is there a way that it sort of bridges to the next thing? Like, if this doesn't do the trick, this is where you go next, or
Absolutely.
there?
So part of stepped care and tiered care systems is exactly where I hope these kind of supports can end up and be evaluated. And one really exciting project that is really being led by my doctoral student, Mallory Tobias, in collaboration with Phoenix Children's Hospital, is we're adapting our therapist-delivered single session approach for use in pediatric emergency departments for kids that are coming in with suicidal crises, self-harm, because often they're only in the ED for a very short time, and the opportunity to intervene is quite limited. So doing something and ensuring that folks have a coping plan that they're leaving with that they feel good about, along with a safety plan, is something that's really important to streamline and standardize. So we're going to be evaluating the utility of that on top of the regular follow-up services that they would normally do at the hospital. So seeing if it has an added benefit over and above what's already in place is definitely one direction to go. When we offer our single session consultation to folks on therapy wait lists, invariably, some subset of people tell us, you know what, I'm good now. Yes. And, in our first trial, something like 10% of folks we called everyone after 2 weeks and said, do you want to stay on the wait list? And 2 of them said, honestly, my symptoms inventories are 0. I don't think I need it.
Yeah.
And so some subset of people may respond really well to single session approaches. Not everybody, not most people. But if we can implement these broadly, that creates an opportunity to sort of unclog this really overburdened mental health care system, at least to some small degree, to get people the help they need faster. And for some folks, that might be all that they need.
Right. So that I think you covered the 2 things that I've been particularly interested in, which is one is shortening wait lists, and the other is helping out in psychiatric emergency rooms. So were you saying that you were doing it with pediatric emergency rooms or psychiatric emergency rooms, or both? Or?
Yes. So sorry, I misspoke. I said pediatric ED, but it's really psych ED for young people at Phoenix Children's Hospital. And Mallory Tobias is leading the way with that.
Because, one of the things that we've got is lots of kids coming into emergency rooms, and then they get stuck there because somebody thinks they need to be psychiatrically hospitalized, and they may need to be psychiatrically hospitalized. But if there are, sort of fewer people ahead of them that don't need to be hospitalized because they actually got, help with something else, that's obviously made a big impression.
Yeah, absolutely.
So
there are lots of directions, and we're really at the beginning of exploring what's going to work.
What's been your biggest disappointment about this? Besides the fact that it sounds like you've run into people that have put up barriers where, as far as you're concerned, they weren't necessary.
So I think my biggest disappointments more like confusion. I'm not disappointed because that implies I've given up trying. So
I can see you're a perfect person to come up with this intervention.
The biggest source of confusion to me has that not been the implementation barriers, so to speak, with the organizational stuff, but just as sort of a healthcare system, I've been so shocked with how disempowered young people are to make their own choices, and to get things they need, regardless of whether their parents approve of mental health support, and how little attention there's been to that issue. There's been some, but particularly in the research world, going for parent consent waivers and parent permission waivers, which is what we've obtained for our research studies mostly, is so difficult and so unprecedented in many situations. And given the reality that most kids in need get nothing, that many kids, with many teenagers in particular, with depression, anxiety, suicidal thoughts, those are invisible problems in many cases. And parents often don't know, or the reporting discrepancies are huge in what these teens are going through. Teens deserve autonomy to some degree, and I think a greater degree than the system currently allows. And I've been really amazed at how little movement or attention there's been, at least in the research sphere, to that point. And that's been really, really confusing to me and really disappointing, but also motivating to explore what can be done on that front.
Well, I think part of the thing is you're using their autonomy to help them. I think sometimes if their autonomy is getting them drunk or doing dangerous things,
double-edged sword.
That ends up being a little dicey. So I think that's part of the problem.
Totally.
With autonomy. I think I used to say for parenthood, the trick is giving kids enough rope so that they can explore, but not so much rope that they hang themselves.
Yes. And I think expanding the amount of rope available in terms of accessing mental health supports is very different than expanding autonomy in the direction of being able to go out at all hours or that sort of thing.
Mm-hmm.
But yeah, I would say that's the biggest. The other thing that I can think of is there's continued, I think, resistance and confusion from many clinicians about single session interventions and what they are. A lot of folks I speak to in the research world and in the clinical world sort of just don't believe it, which has been really interesting because there's so much data. So I'm just going to keep talking about it and keep hoping that folks are at least willing to see the possible applications of these kinds of.
Well, I think one of the reasons that I'm really pleased that you were able to join us on the chats today is because I think it's important for people to hear what single session interventions do and what they don't do.
Yes.
You're not saying that if you come to see me with disseminated tuberculosis or pancreatic cancer, that you're going to talk the person out of having that problem in a single session. That
Nope.
That's right. That there is a place for that for a single session intervention, and that you can call off people who can use that and run with it. That's not going to be everybody. I mean, your effect size was about 0.3 or 0.4. There's obviously a lot more room for effect, but that's better than an effect size of nothing. And so I think knowing like with any treatment, knowing the limitations and knowing the possibilities is really what we do.
Exactly. It's one of many tools that I hope is more broadly used and helps those that it can help. Of course, that won't be everybody.
Mm-hmm. Well, I personally have really enjoyed hearing more about this. I was sort of there in the beginning when you came to Stony Brook, and you've obviously really run with this. We look forward to posting your link on our website. And I thank you again for joining us and telling us about it this morning.
Thank you so much for having me.
And thank you all, our listeners, for listening. Thank you all very much for tuning in. This is Gay Carlson for AACAP's Screenside Chats.
Provides Screenside Chats as a member in public service, but it is neither a legal interpretation nor a statement of AACAP policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by AACAP. The views expressed by guests are their own, and their participation in Screenside Chats does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests are their own and do not necessarily reflect the views of AACAP or any of its officials.